There are a number of developments in implementation science that I'm very excited about that are relevant to FH. So I want to highlight those before I talk about some of the difficulties in the field. Specifically, I love the idea that we can do research that centers both effectiveness of interventions and implementation at the same time. And this is an innovation that was described by Jeff Curran, who's based at the University of Arkansas. And he talked about three different types of hybrid effectiveness implementation trials. And as we build evidence about how to improve care globally and specifically in FH, this particular trial design or approach is really, really important in um, centering or escalating, elevating the attention to both of these at the same time. We've also seen some developments in terms of quasi-experimental trial designs. So we tend to privilege the patient-level randomized controlled trial in biomedical research for very important reasons, specifically because it helps us deal with confounding and threats to inference. But for many reasons in implementation work, it's hard to randomize at the patient level. We end up using a quasi-experimental approach. So we've seen some innovations in this space, specifically with the use of stepped wedge trials, where we have multiple sites that roll out an intervention over time. Usually, ideally, you would randomize the timing of that rollout to deal with some threats to inference. But we're also seeing some adaptive trial designs, specifically looking at different implementation strategies. And so, as Dr. Mittman mentioned, we want to make sure that our implementation strategies account for context. Sometimes you have a very good idea about which implementation strategies you want to use, but those ideas are sort of an educated guess. And so in these adaptive trial designs, you can start off with one implementation approach, see how it works, and then for sites or places or people that don't respond, you may a priori decide to change to a different strategy. And you can do that successively over the course of a study, trying to get some efficiency from having it all built into one study, but allowing you to study more than one implementation strategy or set of implementation strategies. There are also behavioral economics informed strategies that are being increasingly brought into implementation science. And I'm so proud to be at the University of Pennsylvania, where we see a lot of work in this space using nudges, defaults, and other strategies that are employed in behavioral economics to catalyze behavior change with respect to healthcare. We have more measures now. So when I started in implementation science about 8 years ago, we were leaning really heavily on qualitative measures, in part because of the richness that qualitative inquiry brings, but also because we didn't have a lot of validated measures. And so we're seeing a lot more movement in the measure development space in implementation science, which helps us be more precise about the concepts that we're measuring. And it allows us to talk sort of across fields and across institutions about implementation progress. So the stages of implementation completion is a concept that was pioneered by Lisa Saldana. And then the acceptability, feasibility, and intervention appropriateness measures were developed by Brian Weiner and colleagues. And so that helps us have a common language about the implementation outcomes that describe studies to improve the uptake of evidence-based practice.